Welcome to the podcast. I'm your host, Jim Jorgenson, and joining me today are Derek Imars, Executive Director of Pharmacy Supply Chain at Indiana University Health, and Steve Rao, Chairman at Visante. Welcome, guys.
Thanks, Jim.
Thank you.
Steve, before we dive in, can you briefly reintroduce yourself and your role at Visante and maybe give us a little of your supply chain experience?
Yeah, I'd be happy to. I guess I should start out by saying I spent the majority of my career serving as the pharmacy executive at UW Health in Madison, Wisconsin, where I was responsible for all aspects of the pharmacy enterprise across the system, and specifically germane to today's discussion on supply chain. That's where the role where I learned firsthand about the importance of, and I would say the opportunity in driving value through innovative and high performing pharmacy supply chain practices. Specifically, I learned in the mid 2010s how to establish a strong business case for a consolidated pharmacy service center. I learned that lesson three times. So it took three times to get that business plan and pro forma through the capital funding process. But once we were successful with that, gained a lot of experiences of implementing a world-class pharmacy consolidated service center to drive significant value for the organization. And honestly, supply chain practices were at the core of the return on investment for that CSC. Then fast forward in the early 2020, I made a major career shift and joined Visante, where I worked with you, Jim, to lead our health system division. And from 2020 to 24, we experienced tremendous growth and success, establishing long-term partnerships with many hospitals and health systems across the country to help them accelerate value and help transform healthcare through pharmacy. Then in early 2024, I transitioned to the CEO of Visante and into the chairman role most recently, where my role today is primarily focused on strategy to help the company grow and assuring the work we do exceeds the expectations of our clients.
Thank you. Derek, can you share a quick overview of your role at IU Health and maybe the scale of pharmacy operations that you're supporting?
Definitely. Thank you, Jim and Steve, and it's an honor to be on the podcast. Currently, I serve as the Executive Director for Pharmacy Supply Chain at Indiana University Health. We are the largest health system in the state of Indiana, and we do have a centralized service center to Steve's point. My pharmacy journey began with Ascension Health, and I spent about 4 years at the bedside, really beginning to understand and learn the nuances of practice, but also connecting the dots between where we could improve from an operational standpoint and determining how we could take some of that statistical rigor that we apply to our clinical decision making and really bring that forward to our operational practice. And so, like several young pharmacists who want to make an impact over time, you eventually develop an interest in leadership. And I started my formal leadership journey again within Ascension Health, and that took me on a definitely an interesting pathway of discovery as I supported local facility level work, but then had the opportunity to manage and support a market. And then eventually my journey took me to the supply chain organization that is contained within Ascension Health. And so at one point I was serving pharmacy supply chain nationally, and really it opened my eyes to where we sit today as a profession, where our opportunities lie, but also it gave me some practical experience on how to solve some of the key challenges that we still see persisting today. After that, I did spend some time in the ERP space. And so as one of two clinicians on a large project for Ascension to change and integrate their new ERP, I was able to apply intelligent automation, process improvement, process optimization to the world outside of pharmacy, but also the world of pharmacy as well. And so that was a really rewarding step in my career. It gave me a lot of exposure to new areas of practice and other parts of the organization that typical pharmacists don't encounter throughout their journey. And so that did help me register and start to ideate and bring forward some of what I do today in my current role at Indiana University Health. I would say currently my career sits at the intersection of clinical care, operations, and enterprise supply chain, and that lens shapes everything we do today with our work for our patients.
Thank you. Let's first talk about pharmacy as a strategic enterprise asset. Pharmacy is evolving from a cost center to a strategic driver of enterprise value. What's propelling that shift from your perspectives?
I agree, Jim. I think for decades, pharmacy has been seen as just a cost center, and that narrow view really restricts and abbreviates our ability to impact health systems. As we look forward and as we have adopted and brought specialty pharmacy to the foray, really highlighted infusion therapy and the ability to grow into a strategic asset through that work. I think health systems are starting to realize that pharmacy is making more of that bottom line, so to speak, and they're seeing that there is definite opportunity in having that pharmacist join the C-suite, get a seat at the table for key decisions, and if they want to continue to grow in the market we're in with the regulatory changes, margin compression, et cetera, it's critical to see pharmacy as a strategic enabler versus the legacy cost center. I do think looking forward, if you take a look at the progression of pharmacy practice, most of our growth does occur in the outpatient space. Again, that's where our specialty prescriptions are distributed through either mail order, central fill for our health system, and in infusion. And so anything we do in that space to contribute to patient care has shown a great return on investment, and all of that is anchored by the 340B program and our ability to extend care to patients who need it and support service lines that really meet the patient in the continuum and where the health systems are providing care, which is, again, that outpatient space.
I might just add, I think this is consistent with Derek's comments that pharmacy is one of the last frontiers of significant ambulatory revenue and margin growth opportunity anywhere in healthcare. It's a huge expense line, which I think traditionally has always garnered a lot of attention, but it's a huge expense line that, when managed well, drives value in all areas of every health system's strategic goals, not just financial performance, but also operational efficiency, better quality care, safer care, patient and provider satisfaction, safety, compliance, research, quality, the whole gamut, right? Ambulatory pharmacy and pharmacy when done well drives value in those areas. So I think specialty pharmacy and ambulatory and home infusion, as you brought up, Jim, they bring significant revenue and margin growth opportunities and upside to just about every health system in the country if done well and focus is applied and discipline applied to achieve that significant growth. And those ambulatory growth areas perform best when supported by a strong and, I'll say, innovative contemporary pharmacy supply chain practice, including 340B as it wraps up to part of the pharmacy supply chain in the way I view it. So greater upside in specialty and ambulatory pharmacy when you have higher performing pharmacy supply chain to elevate it.
Excellent. Derek, in the past, you've spoken about a purchase to patient strategy. What does a purchase to patient model mean in actuality?
When looking at the purchase to patient operating philosophy, a lot of that was taken from, for me, it was initially a way for me to describe what I do to folks within the organization or outside of the organization in terms of my roles or responsibilities. But it's grown to something that means much more. And I see it as the bridge between our clinical practice, our operational practice, and financial sustainability. If you look at the pharmacy supply chain, there are multiple nodes that make up the entirety of the supply chain. And a lot of our decisions that drive value, they're made at different intersections and different nodes throughout that process. And so for me, it's understanding along the way, how can we optimize those singular nodes to make sure that we're not only driving the best results for the organization, we're making sure to be good stewards of our resources, but we're also trying to actively make the patient experience better and to serve our partners and other health professions, including nursing and our physician base, in ways that they may not have been able to appreciate before. And so that strategy is really core to a lot of the work that we take part in at IU Health, and it serves as our theme for the pharmacy supply chain and the direction of our strategic roadmap.
How does aligning supply chain across that full medication journey really create value for the health system?
Definitely. First, I would say it definitely ensures safety and reliability by removing the fragmentation that leads to drug shortages and waste. I start there just knowing that we're only 4 to 5 years removed from some of the severe impacts of COVID. And so understanding that when you have a proactive system in place to take care of patient care, we're able to move upstream and mitigate a lot of the downstream impact and labor and resource expense that's associated with planning that's not as favorable or consistent. I'd say it also provides the infrastructure needed to scale complex services like specialty pharmacy, home-based infusion. Steve mentioned AICs, AISs, and it really ensures that as we move into those spaces, we're taking advantage of being able to provide new service offerings and grow that margin base in a new space. But we're also considering from end to end, kind of going back to the purchase to patient strategy, we're tying out all of that value so that we're not losing any of it. Thirdly, it creates enterprise value by standardizing products and strengthening access, turning the supply chain more into a steward of the organization's financial health. It brings that from the back office forward to the front and highlights our ability to meet the patient where they're at. And again, we've grown beyond just the four walls of the hospital. We do provide and support all classes of trade at Indiana University Health, and each of those environments offer different economic drivers that we detail into and ensure that we're staying on top of.
Where do you guys see the biggest gaps today in how organizations are approaching this?
Yes, I would say the first major gap is really, I think, how we measure success. And I alluded to this earlier, but historically, pharmacy is seen one-dimensionally as an expense reduction category. And some of the conversations we've had with our local finance folks is tied back to the idea that we are moving beyond just a cost center basis to more of a driver and a strategic engine to grow margin in various spaces. And so in order to capture our value and really effectively tell our story to the C-suite, we have to expand from that one-dimensional model that just focuses on expense and move into spaces where we can say we not only provide expense reduction, but we provide other value modalities, including waste management and reimbursement improvement. As this audience knows, again, if we want to take an example here, if you look at a biosimilar agent from end to end, there are a number of reasons a health system would select one, two, or three to add to their formulary or their portfolio. And ensuring that you have all the detail you need from the managed care side through the purchasing side to the actual dispensing and then through rev cycle, it's critical that we take the whole picture into account and not just silo our different opportunities and drop some of that value in between the cracks of the coordinated care. And so that's a piece of what I see today. And I think as we continue to move forward, it'll be imperative as pharmacy tells its story to capture that value differently.
Yeah, you both mentioned a key supply chain element for multi-hospital systems as a central service center or a CSC. What role do CSCs play in modern pharmacy operations?
I would say my experience with our centralized service center, it was opened in 2023. I'll give a short background. We do provide services that range from sterile compounding to non-sterile compounding. We have a large pediatric base within the state of Indiana that we care for, but we also perform strategic sourcing, clinic distribution to several of our 400 plus physician office clinics. And there is a central fill and specialty process that's under one roof. And so the system pharmacy team aggregates there as well. And so there's a lot of opportunity to cross collaborate and be in the same space. But in terms of what a centralized service center does, to me, it's more than a warehouse. It's really a force multiplier for a modern health system. So whether it's providing the footprint for a new scalable clinical service that meets the needs of the patient in the field, or we're learning to optimize and insource our own proactive secured allocations to ensure that when a shortage occurs, we're ready for that shortage and we don't have to sit in a responsive stance. We're more proactive. I think that's where the CSC has driven value. The last piece I would say is that it is interesting to study the pharmacy supply chain and understand the economics of our manufacturers, our wholesale distributors, and other partners. There are times where I always say that the CSC is really built to support economies of scale, but there are considerations that we can make and pieces of the industry that we can carve out specifically to insource and leverage the facility to more effectively manage value. One of those areas I share typically is our internal consignment program that we're developing, where we maintain centrally through RFID technology consignable products like a wholesale distributor would, but these are items that are not typically on consignment portfolios, and they are at high risk of waste. And so we're able to implement a transparent view of that product all the way through its life cycle and move it around as needed in a way that's both compliant and effective for the sites and the patients.
And I think, on a national level, fortunately, I think most leading health systems are starting to understand the connection with their investments in a pharmacy CSC and driving more value for the system. We're seeing a larger number of clients, mid-sized, large multi-hospital health systems wanting to partner in that area. And so it's really nice to see the concepts that started 10 years ago starting to take hold and really be invested in, because they can be, 20 to $50 million investments. Sometimes the pharmacy piece of that can be less if it's integrated with other departments like lab or supply chain, for example. But we're starting to see more and more health systems recognize that that's an investment that'll pay for itself in just a matter of a few years if they design it right. So really, I think the role where the contemporary pharmacy service center plays is, I view it as threefold. One is it provides space and technology for scalable business, ambulatory pharmacy business, and revenue and margin growth for many years to come in the areas of specialty pharmacy, ambulatory infusion, and even PBM practices, looking at that organization's employee health plan and space and resources to manage that, to keep those costs down and those employees of the health system strong and healthy and independent. Secondly, as Derek alluded to, I think of pharmacy supply chain optimization and innovation, things like strategic sourcing, forward and bulk buys to save costs, the space to better manage and prepare for drug shortages, ways to insource historically outsourced sterile and non-sterile compounding practices, which can save millions in most organizations, repackaging space, and then the thirdly, the warehousing and distribution fits into that supply chain mode as well. And there's a lot we're seeing CSCs do to save significant amount of drug expense and provider time in health system clinics and physician provider group locations through giving pharmacy more autonomy for not just managing the buying, but the distribution, logistics, and minimizing drug waste in those areas as well. And so I think, thirdly, after growth, innovative supply chain practices is just enterprise support and operational efficiency, setting that system up as they acquire and grow in the future. The opportunity to centralize pharmacy to the extent possible. You can do more as you centralize and drive efficiency, have better staffing efficiency, having that as much low acuity work as possible be done in a central manner. So we see a lot of systems where they're able to bring the clinical services, medication access services from the larger enterprises that have traditionally have them and bring those services into the smaller hospital as they centralize without adding a lot of FTE. Using the CSC for that. So it drives operational efficiency. It brings leadership teams together and helps pharmacy leaders coordinate it better. In a lot of cases, it improves regulatory compliance, especially in the sterile compounding and narcotic distribution areas. So lots of different ways, financially and non-financially, the modern CSC, it just makes sense as the next horizon for investment in pharmacy. And again, we always try to build them for 15 years in the future because it's the size of an investment. You get one time to do it, so you better do it right the first time.
How do you guys go about balancing standardization through the CSC with the need for flexibility at the local level when you're servicing so many different hospitals?
That's a great question, Jim. I think, to really balance that tension between standardization and local flexibility, we've learned to solve it through clear role definition and function. And so we try to engage the field and consistently not only tell our story to the C-suite, but work that into the operational process and rigor for the sites. They definitely understand how we're engaging. And so one of the ways we do that is through our centralized pharmacy purchasing team. They're able to engage the facilities and help them understand in real time as they order or as they commit to certain buys what our standard process looks like internally and what services we provide them. And so there's a layer of social and resource infrastructure from the human side, but we also ensure that as we engage the field, if there are areas of efficiency that we can support and stack, we try to be visible and try to visit their facilities to scope and understand how we can insource that ourselves if it will benefit the rest of the health system. Typically, what we do see and what we hear from our facilities is that because of the work we do at the CSE, that gives some time back for them to handle more of the nuanced pieces of their work and scope.
And it can't just be about pharmacy, right? The investment in the CSC needs to bring value to other stakeholders, specifically to nurses, to physicians, to the finance team who sees better results, for example. So the more you make it a team effort, not just about pharmacy, but about you tie it to the organization achieving its goals, the better you're going to be. You're better off you're going to be, and the more successful you're going to be. And you don't just centralize and standardize for the sake of centralizing and standardizing, right? There might be some elements of the health system that you don't want to centralize and standardize. And so you got to listen to that and recognize if you're going to standardize and centralize, it better be to drive value, and you better put resources into measuring the value and listening to the stakeholders and making sure their needs are met.
Derek, you mentioned drug shortages, and those continue to challenge health systems. What's changing in how leading organizations like IU Health are managing this?
Great question, Jim. I think COVID really exposed where we were from a foundational perspective in terms of drug shortage management. And during that time, I was at Ascension Health, and we were really able to see what that impact looked like across 12 different states within the United States. And the work that took place after that really focused on consolidating data, ensuring that we had a good idea of our stock, but also tying that to velocity, days on hand usage, et cetera. And so a lot of health systems, if they had not already, they were developing more of those reactive measures and markers that you'll see embedded throughout each of the health systems in the country. Where IU Health is trying to be different and where we're trying to innovate is it's important to have these data sets, dashboards, weekly stand-up calls, communications about substitutions and alternatives, but we really are working to drill down on understanding how to leverage the CSC to help with some of this work, but also to partner with some of our vendor partners to ensure that some of the risk that's associated with carrying a lot of that extra asset is outsourced. And so we do have engagements with our GPO to set up a proactive secured allocation list. That listing is predicated on our critical product list that we developed. And so that listing was reviewed locally with our clinicians. And again, in partnership to Steve's point, we want to make sure we're getting feedback from the field. Anything that's not contained within that GPO offered service is registered and brought in to the CSC. And so we carry that product locally. This allows us the ability during a shortage to say, hey, we've got the product we need to continue clinical services. We don't have to belabor and go into master data management changes, issue communication that is sometimes fragmented and broken across the health system. And we're able to uphold and maintain a level of safety that wouldn't be there, I would say, without the ability to rely on those proactive secured allocations.
A core supply chain element is the pharmacy purchasing strategy. How should health systems be thinking about pharmacy purchasing today?
I would say pharmacy purchasing has definitely moved beyond just simple order placement. And to add to that, the invoice or the price point at sale is not the only thing we consider. And so in a modernized pharmacy supply chain, I'm seeing a few trends for myself, and we've been able to contribute to those. And so centralized purchasing and standing up a group of individuals that are highly specialized in this process is a key trend that I've seen across the country, as well as the ability to integrate technologies that help us understand price changes and value pathways at scale. And so if you look across various classes of trade, and if you consider 340B, there's a lot of complexity inherent with that and manual work. And so it's important to pair solid standard process and standardized central teams with the technology to make sure that we're leveraging and getting the most value at the point of sale.
Jim, I think how I think about pharmacy purchasing today is that it's very nuanced and it's more dynamic, more complex than ever before. And back like when we started our careers, it wasn't the case. Pharmacy, like most drug expense, was in the acute care environment, and most health system drug expense had a GPO contract associated with it. But that is no longer the case. It's completely flipped, where most organizations that are successful in pharmacy are seeing 90+% of their drug spend in the ambulatory environment across multiple sites of care. And so the linkage between supply chain and drug purchasing, patient care, revenue cycle performance, drug expense, and regulatory compliance, like that intersection with those four areas is now massive. So I don't think most legacy hospital supply chain executives understand that. I don't think most CFOs understand it, but pharmacy leaders certainly feel it and see it on a daily basis.
What do you think the risks are of continuing to treat pharmacy purchasing like general supply chain?
From my standpoint, I think the objectives and the outcomes, as Steve alluded to earlier, are very different between a traditional supply chain and a pharmacy supply chain. And I think it starts with the economics and the idea that supply chain focus really rallies and centers around the cost of the drug, whereas pharmacy ties more out to expense reduction is key, but we mentioned that the multiple dimensions of value. We're looking at reimbursement, we're looking at margin, we're trying to better understand in the big picture, are we regulatorily sound? What risk are we at with the practice we're engaged with? And there are more stipulations for pharmacies today now than ever. And so it's really important to understand those nuances and to have those baked into the DNA of what you're doing. And if you're not able to really conceptualize those pieces, you could be missing a big part of the value proposition and also putting the organization at risk.
Yeah, I think Jim, just to follow up on that, I see the risks, and it's sort of what I mentioned before in like 5 buckets. One is patient care. That could deal with the supply chain practice has an impact on the EMR build accuracy. If you don't build the EMR accurately, patient care suffers and revenue suffers as well. So like clinical evidence and patient specific drug needs are they're prevalent now, and that wasn't always the case in the past. So patient care can be put at risk, revenue cycle underperformance, and it's not just like how much you charge, but it's how much you capture once you generate that charge. That overlaps with EMR accuracy, which overlaps with P&T committee decisions, which overlaps with needing to purchase multiple products from different vendors based on different sites of care and drug availability. So I think revenue integrity is at risk. Clearly, Derek made the case around higher drug expense, but it's not just all drug expense. You can experience 340B underperformance as well, which is going to increase your overall drug spend. And lastly, like the supply chain practices are close to, they're highly regulated. The Drug Enforcement Agency, the DSCSA, et cetera. So there's regulatory risk as well if you treat pharmacy like general supply chain.
Despite what you guys just said, though, I think there is a trend towards consolidating pharmacy supply chain into broader hospital supply chain. So, what are you guys seeing out there in that respect?
I have seen some of that, Jim, and I really, as an individual who's worked within a supply chain organization with a pharmacy lens and focus, I would challenge that to several of the points that Steve brought up with the, maintaining and keeping that patient at the core of what we do. That, pharmacy and supply chain can coexist, and they can learn from one another. And I propose that that's a better model than just having the two come together to keep pharmacy and its unique DNA separate from what supply chain is doing, but integrate the bright spots where it makes sense and leverage some of those opportunities. So some of the work I've seen in the pharmacy supply chain space is if you take a look at how we've practiced over the last 25 years, we're now starting to develop more automation techniques. We're better managing procure to pay pathways. We're making sure that our AP processes are intact, but we have a ways to go. I would say that the traditional supply chain over the last 25 years, with the popularity and the rise in usage of ERPs across enterprises, that has made them more structured in a lot of ways and provides financial visibility and internal purchasing and inventory controls that we've not been able to appreciate for some time due to our footprint. Again, learning from them and bringing that work into what we do is key, but I do think they have something to learn from us as well. And so there's a buzz term in the traditional supply chain space. Currently, it's clinically integrated supply chains, and I feel like pharmacy's been doing this for over 40 years. It's a part of who we are, and it starts with our governance groups, and it trails all the way down to the patient. And so, in ways that we can engage and support supply chains with saying, hey, we've been here before, we've done this work. How can we partner? I think that's the right model as we move forward, is to take the best of both worlds, but allow for that independence and that statute to stand, that pharmacy is its own separate supply chain with its own complexities and value propositions for our patients.
And I think, in terms of like a national perspective, I mean, my opinion is this: traditional supply chain focuses on standardizing products, negotiating prices, ensuring product availability, inventory management, and complying with GPO contracts. And I think, 20 years ago, that traditional supply chain emphasis that I just mentioned paralleled what pharmacy was responsible for. And I think all those things are still very important in pharmacy, don't get me wrong. But the shift from acute care to massive ambulatory growth, including the 340B program and the need for drugs to be purchased not just efficiently, but under the right site of care contract at the best possible price, brings a lot of complexity. You think about the growing drug expense and volume of biologic drug use, gene therapy, and the close linkage of like when you give a gene therapy to a patient and how closely tied that is to overall revenue cycle performance. Like if you don't get that perfect with pharmacy, shepherding that process for those high cost drugs, you can lose $2 million per patient right there if you don't do that right. So I think, as I mentioned, pharmacy supply chain has become more and more nuanced. It requires a lot greater flexibility and nimbleness to optimize overall clinical and revenue cycle performance. So, but to answer your question more directly, I think probably between 30 to 40% of hospital health systems we work with either have or they are in the process of considering, should we transition pharmacy supply chain governance away from pharmacy to supply chain? And like Derek, I think that's I think it's a mistake to do that. I think about the word accountability. So the systems that maintain pharmacy accountability for overall pharmacy supply chain practices, they perform better in my experience in terms of financial performance, both on the cost and the revenue side, and on physician satisfaction with the services pharmacy provides due to pharmacy's ability to be agile. So, Derek, I think the right model is collaboration, right? The right model is pharmacy accountability, but collaboration between the pharmacy team and the supply chain team as equal partners to working together to do what's best for the organization and patient. But that ultimate accountability should reside with the pharmacy executive and their team.
Well said. Let's look at two key ambulatory areas that you both mentioned: infusion strategy and specialty pharmacy. And certainly infusion continues to grow rapidly. What role does supply chain play in supporting that growth?
That's a great question, Jim. We are in the process of transforming our infusion process to be more multimodal, to expand and move beyond just our HOPD clinics, but really optimizing home infusion and AICs and AISs to meet our patients where they're at. And I get excited about this work because I know in the state of Indiana, this is going to open up and allow our specialists more access and time for our patients to come in and receive therapy in a place that's convenient, but is also wrapped. And I've heard this on the podcast, and I like the analogy. It's wrapped in managed care and revenue cycle theory and tied out to patient practice. And so where I see the pharmacy supply chain sitting underneath that all is it's a strategic underpinning for how we get the product where it needs to go. And so at IU Health, we, like we talked about earlier, our CSC is under construction currently, and we are making more facilities and more space available to support AIC, AIS practice, and home infusion. And we're consolidating that work at the facility so that the purchasing controls and all of the great work that we're accustomed to at the facility, that still flows through and is distributed across the health system in a way that make sure that the lift is sustainable and that patients and providers know what to expect from the CSC. And so as we move forward, we are cognizant that the supply chain does include, like I said, managed care and revenue cycle services, but we also want to make sure that we're partnering in the selection of some of the products that are administered to our patients. We've mentioned biosimilars and some of the non-oncology growth that's occurred over the last few years. It's really important that we partner with our drug policy partners and our central access teams that help with the prior authorizations and making sure that everything is set up for the patient in the correct way. We need to be at the table informing them on the right pathway so that when they work with that provider to submit an order and set that patient up, they've got the right drug based on that patient-specific need, first and foremost from a clinical standpoint, but it also ties back to the continuity of care, ensuring that, hey, we're going to cover, we're going to work with you to make sure this product is covered, and we're going to make sure that it's administered in a safe way that gets you to the point where you want to be with your health.
You know, and I'd say we still see a lot of health systems across the country where they have two sites of care for infusion. They have the traditional hospital-based infusion site of care, and that obviously, has always done well and been a boondoggle for hospitals financially. But we also see a lot of areas where physician practices administer infusion within their offices. And I tell you what, we see a lot of systems where we walk in and analyze that environment, and they're losing money when they think they're making money, or they're making like 3 to 6% profit margin in those areas. And as soon as they get pharmacy involved and start building out pharmacy infusion suites and having pharmacy manage that drug expense line and the revenue line, you can see those profit margins go from 25 to 30%. So you can see a six-fold difference in profit margin in the ambulatory infusion sector just by engaging pharmacy to drive both the ambulatory infusion suite business, the patient scheduling, the revenue cycle, and the supply chain decision making. And by the way, patients get equally or more convenient care in those settings as well.
For specialty pharmacy, with the rise of high-cost specialty medications and more complex contracting, how is supply chain evolving to support that?
That's a great question. I think the evolution of the pharmacy supply chain is most visible in how we handle these medications. And again, we've moved beyond simply just reducing the total cost of care. That model is antiquated, but this one really integrates into the supply chain, managed care, PBM contract favorability, depending on the way in which the patient receives care and the level of care. It's important to consider. In this high-stake environment, it's really important that we move upstream of the revenue and understand implications before we even purchase the drug. And so I've said this before, when a single dose costs as much as a luxury home, for CAR T treatment or gene therapy. The supply chain, it's not just logistics. It becomes an essential clinical strategy that is important for the health system to recognize and to empower. And so as we move forward at IU Health with our process, we do have a committee that looks at these higher cost treatment drugs, and we are working to partner to better understand how do we, float some of these costs? What does cash flow impact look like? Are we making sure that as we consider these products, do we need to specialize and hone in on a certain number of gene therapies, right, that fit our patient mix and our provider footprint? And so there's a great there's a great amount to consider, but I think making sure that we're telling the story to the C-suite and helping them understand that these drugs cost millions of dollars, upwards of 4 million a dose, is key. We're optimizing our stewardship financially, so we're making sure that we're working very closely with our finance partners. And then we're also reducing risk. We need to leverage technology throughout the supply chain to make sure that, again, going back to the purchase to patient philosophy, as we interact with each node in that pathway for a patient, are we getting the most out of that value that we can, but are we considering the total cost of care so that we can afford these really expensive agents that provide, I would say, modern day miracles for several of our patients.
What new capabilities are you seeing that are being required to manage that level of financial and operational complexity?
I think at this point, where we sit today and the technology really speaks for itself, but understanding first the data, right? How many, what does our ecosystem look like? What does the population look like in terms of who needs to access this care, and where do we have concentration of effort to ensure that there are efficiencies built into the model. But for us, it really ties back to understanding and ensuring that the P2P process, right? If we were to stick with the theme for CAR T, as we purchase these items, we want to make sure that each end of the process, from making sure a supplier name is updated in our ERP, which is the driving force for our financial system, to ensuring that as the product makes its way through our care teams, that we have all of the considerations made for the patient at every step of the way. And so we are integrating and updating our EHR platform to Epic in the coming year. And I think given our current circumstance, that is an area of growth that is not only needed for these higher cost therapy items, but also for our broader infusion strategies where we're trying to increase and improve access. And so those data elements, those connectors with technology are becoming ever more important, and it's critical for us to take advantage of them.
You both noted regulatory pressures for pharmacy supply chain continue to escalate. How are regulatory requirements like 340B and DSCSA impacting supply chain strategy?
That's a great question, Jim. I would say that 340B, it's no longer an individual responsibility of a facility. It requires a centralized approach that is pharmacy-led, has oversight, and works to really protect those savings and those margin gains so that we can fulfill the mission of the program and extending care to those who are poor and vulnerable. And so, looking at strong TPA partnerships where we're ensuring that the third-party administrators are aligned with our operational goals. We have a CSC. There's a lot of work that goes into orchestrating and making sure that the nuanced operations that we hope to achieve are accounted for with this process. Sophisticated sourcing is another piece of this puzzle, and making sure that we're utilizing WAC neutral models and sub-WAC sourcing to maximize outputs is key. In terms of DSCSA, it's taken some time to get here, but I'm proud to say that IU Health was ready for that implementation, and we really, as a team, try to hard code safety into our purchase from anything that hits our doorstep. And so our platform is robust. I think we've had at least 2 years in of consistent compliance and readiness from our end. That's allowed us to better understand abscess verification and pedigree integrity, or it's given us insight into, well, maybe we need to make this the standardized change after after the wholesalers went live. And so I think those two areas, it's important as anywhere in the organization to make sure that we're conceptually considering them in every step of the process, and ensuring that process matches data, and that data is consistent with what we want to see for the patients.
Looking ahead in terms of challenges and opportunities, what do you guys think the biggest challenges health system leaders should be paying attention to right now are?
You know, I'm gonna steal a story from Jeff Bezos, and I thought about this, Jim. He noted that when Amazon was pulling forward and becoming more predominantly known in the industry, that he had a set of executive leaders that he hired and brought in, and one of his leaders told him at one point, and it was a shock to him, that um, in the work that he did, he was an ideas guy, and he liked to implement and layer in multiple priorities for his teams. And the individual that he hired onto his team shared with him, Jeff, ultimately your ideas, they might kill Amazon. And so I heard this, and it stuck with me. And after a few days of thinking about it, I think, at a very high level, if we don't drill down into the specifics, I think that the number of priorities from changes with CMS and the government, or to the 340B program, or to the supply chain in general, involving new tariff stipulations, or access to appropriate drugs and API sequestration. Will these priorities, if they stack up, how are we coordinating and making sure our teams are sequentially ready for these challenges that really they don't care about our timetable. They occur, and then they move forward. And so how do we prepare entire health systems to absorb that in a way that still allows us to extend care, and ensure that we're doing it in a safe way, but also in a way that's financially sustainable?
Well, this has been fantastic, guys. Maybe one more question. If you could both leave health system leaders with one key takeaway on pharmacy supply chain, what would it be?
I would
Go
say
ahead.
I would say that ultimately, most successful health systems of the day will be those that industrialize their operations to individualize their care. And so we've talked about the pharmacy supply chain and the various nodes, but by really by centralizing this infrastructure, ensuring that we have facilities like CSEs, ensuring that we're at the table and we're proactively pursuing growth areas like infusion and specialty, that allows us to have a certain vantage point on the health system, where we can understand the complexity tax of these operations, and we can step in and say, we can achieve this for the health system, and we can do it in a way that's efficient because we've done it before in the past, and we'll do it again in the future. And so I would say that continuing to build that model at your health system, and not resting on your laurels in terms of operational excellence, and what you think is possible. I think that's the piece I would like to leave with the field, and for them to understand that pharmacy supply chain is something that makes us unique as healthcare professionals, and we're able to impact a lot of patients through them.
And thanks for taking that first, Derek, because I'm glad I get the last word on this one. So I've got one answer, Jim, but I'll break it down into four parts. How about that? I think, first of all, for health system leaders, and my answer here goes just like the rest of pharmacy, you need to think about and invest in the pharmacy supply chain as a strategic asset within the organization. You need to make sure your pharmacy supply chain leader has ample resources to get the job done and have high expectations around deliverables. So I know supply chain doesn't traditionally drive revenue, but it provides a ton of value, sets up a lot of other areas around the organization to drive great revenue margin, and it keeps the clinical enterprise humming. So have that pharmacy supply chain leader at the table when they ask for resources. Sure, they should have to give an ROI just like everyone else, but trust them and give them the resources, and then have high expectations and measure performance, and look what happens. Secondly, I think the best, as we talked about, the best model for pharmacy supply chain governance is where pharmacy has ultimate accountability for that performance in very close collaboration with the VP of supply chain. Teamwork makes the dream work. And I think thirdly, when invested in, and the investment's important, designed and managed properly, a pharmacy consolidated service center provides the best opportunity for the overall pharmacy enterprise to drive short and long-term value for most multi-hospital systems. And lastly, the CSC, it's not about a building, it's about a vision, it's about culture, and it's about striving for excellence. So success depends on leadership, right? You got to have a strong pharmacy executive that wants to see it happen, and a team around them to help make the vision and the theoretical benefits of what can be achieved within a CSC actionable and achievable. And when you do that, the culture improves, the care improves, and the overall system achieves their goals as a healthcare system.
Derek and Steve, thanks very much for sharing your time and expertise today. And thanks everyone for listening.